Good morning. Today we are going to introduce some knowledge about LE and report relevant findings.
Hi, I'm Coach Him. Let us briefly go through the anatomy and nomenclature. Lateral epicondylalgia is a condition of lateral elbow pain caused by overuse and repetitive loading of the wrist extensor muscles. In the anatomy, just next to the lateral epicondyle lies the common extensor origin. It comprises of ECU, ED, EDM, and ECRB, with ECRB as the most affected muscle due to the proximity to the lateral collateral ligament and annular ligament. There are different names referring to the similar pathology currently. LE is a term that means pain over the lateral epicondyle, and either this term or lateral epicondyle tendinopathy are the most accurate terms for this condition, as the main pathology of LE is believed to be a tendinopathy. Lateral epicondylitis are no longer used as there is no inflammatory component in the tendon pathology, and the term tennis elbow as lateral epicondylalgia impacts a much wider population than tennis players.
Hello, I'm Na Hongwei. Now I'm going to briefly talk about the clinical presentation of lateral epicondylalgia. Major symptoms of lateral epicondylalgia involve thick pain on outer elbow. Local tenderness can also be elicited slightly distal to the lateral epicondyle, which is origin of extensor carpi radialis brevis and extensor digitorum. Individuals may also experience increased pain and weakness with wrist movement, especially for extension and gripping. For epidemiology, lateral epicondylitis affects around 1 to 2% of adults in the general population each year. Male and female are equally affected, and typically, adults in the most productive year, which is the fourth decade of life, are more commonly affected. The incidence may also differ depending on the population of interest, as more than half of a mature tennis player reports LE incidents at some point in their career. And of course, more than just tennis players, manual laborers, smokers, and those who repetitively work their elbow have also been associated with higher incidence rates. Now I'm going to introduce some more findings on the diagnosis of LE. Elbow is an intricate complex of different soft tissue, bones, and nerve. First, when we make diagnosis of LE, many alternate diagnostic possibilities that mimic or present as lateral elbow pain should also be considered. For instance, triceps tendinitis, osteochondritis dissecans, osteoarthritis, and cervical radiculopathy. There are two common diagnostic methods specific to LE. First one is the provocative test, which commonly involve Boden test, Mousely test, Coulson test, Mill test, and many more. Second is radiographic imaging such as ultrasound, X-rays, and MRI. For provocative tests, they mainly aim to elicit symptomatic pain of patient by contraction of extensor muscles originating from lateral epicondyle. For example, in Coulson test, patients extend the wrist against resistance to elicit pain. For radiographic imaging, grayscale ultrasound and Doppler ultrasound is commonly used. The former is mainly used to look for hypo and hyperechogenicity and abnormalities associated with LE such as tendinosis and cortical irregularities, and many more. Doppler ultrasound can also be used to further rule out differential diagnosis by detecting neovascularity and inflammation. Ultrasound is usually considered as a gold standard for LE diagnosis. However, imaging can be time-consuming and of high cost in clinical setting. Therefore, we want to investigate whether ultrasound is necessary for confirmation of LE after diagnosis by special tests. To do so, we have set up a search strategy aiming to compare specificity and sensitivity between common LE special tests and ultrasound imaging. And from PubMed and Petro, we have searched some validation study and sort them out according to their Petro score and their evidence level. For ultrasound, we include 4 studies. 3 of them are of evidence level 2, while 1 is level 3. We discovered that the general sensitivity of ultrasound is high. However, high specificity is doubted as one of the studies only show a moderate specificity of 47%. As for special tests, we modified the scope of search to include IMED and ResearchGate as limited results was found in PubMed and Petro. We include 3 studies which are of evidence level 3. According to Soroja and Kuma studies, sensitivities of Mills test and Coulson test are high, while specificity is 0. For Mousely test, sensitivity is only moderate while specificity is very high. Due to a small sample size and low evidence level, we think that results of chair test and push-up test is not suitable despite high sensitivity. Overall, ultrasound has high sensitivity and moderate specificity, while for provocative tests, combined use of Coulson test, Mills, and Moseley test should have high sensitivity and specificity. We conclude that after diagnosis of LE by special tests, confirmation by ultrasonography is desirable, especially in chronic conditions which the current treatment has little effect. Our search might not be entirely applicable in clinical setting, because we did not cover all common LE tests and did not cover subjective examination like the patient-rated forearm evaluation questionnaire and other differential clinical tests. In the preliminary search, we observed that there is an increasing evidence of correlation between LE with abnormality proximal or distal to elbow joint, such as shoulder range of motion, shoulder and back muscle imbalance, and wrist weakness. This showed that physical examination should not be restricted to the affected elbow. Examination of related part may also aid in diagnosis. Thus, we decided to dig deeper into their correlation to see if they can potentially benefit the diagnosis and treatment of LE.
Let's move on to the pathophysiology. In current studies, scholars believe that LE's pathophysiology is a multifactorial that contains three components: tendon pathology, pain system changes, and motor system impairments. Motor control deficit is one of the aspects of motor system impairment, and altered muscle activation plays a big role in it. So therefore, our burning question is, how does muscle imbalance or muscle activity modification contribute to the pathophysiology of LE? Gripping is a common provocation test and a functional task that will elicit pain in individuals with LE. Therefore, we aim to compare the activation level of forearm muscle of individuals with LE and pain-free control during gripping to look for the role of muscle activation modification in LE's pathophysiology. The first two studies compare the muscle activation level with constant grip and pain-free grip respectively and compare with healthy subjects. In Elisa Hayes' study, most forearm muscle activation level increased with time in both groups. However, a different pattern was found for ECR, which showed a markedly reduced activity in LE. While in Hill's study, LE subject has a decreased activity level in ECRB and increase in EDC and FDP. Statistically speaking, the result also shows significant difference in these three groups of muscle, but none in other muscles. Both studies show reduced ECR activity level. With respect of ECR activity reduction as a cause of LE, a possible mechanism referred to as stress shooting may explain the phenomenon. It is a process which tendinopathy symptoms appears on tendons that are deprived of uniform longitudinal load. As the common extensor tendon is a shared attachment for several forearm extensor muscles, the decreased activation of ECRB might lead to imbalance in loading of the common extensor tendon, and further leads to pathological changes in the ECRB portion of the tendon. We also compared two other studies which focus on the difference of muscle activity of the forearm muscles in asymptomatic individuals. They are subjects that were diagnosed LE before, but pain symptoms are healed and does not reappear for more than 3 to 6 months. Wrist extension and constant grip are used as intervention method in two studies respectively for EMG measurement of the forearm muscles. In Elisa Hayes' study, ECR activity are significantly reduced in LE group, but increased in asymptomatic group, though both groups are lower than healthy group. In Roja's study, ECR activity are significantly reduced in asymptomatic individuals comparing with healthy subjects, while ECR activity vice versa. Both experiments suggested ECR activity is altered in LE individuals when performing wrist extension movement, which includes gripping as ECR acts as a stabilizer during the movement. This suggested that there are modification of muscle activity pattern in forearm muscles in the pathophysiology of LE. However, two studies have different readings of activity level of ECR when comparing with different groups of subjects. The two findings may be explained by different theories and models. In Elizabeth Hayes' studies, the increased activity of ECR may be attributable to relative recovery of muscle and reduction in the level of pain. This further implies that pain can decrease activation of agonist muscles and increase the activation of antagonists. Even when pain symptoms disappear, the fear of pain may unconsciously reduce the activity of injured muscle. It may be considered as a consequence of LE. On the other hand, Roja's study suggested the reduced ECR activity level in asymptomatic individuals may indicate a muscle imbalance problem underlying the LE overuse condition. Muscle imbalance is considered as one of the major biomechanical factors underlying cumulative trauma injuries. Repetitive tasks that involve the forearm muscle could possibly reinforce the modified activation pattern, consequently leads to stress shooting and increase the risk of suffering from LE. Most treatment mainly focuses on treating the pain symptoms. This study indicates that functional impairment still exists even when pain symptoms are healed. If the activation pattern is not corrected, it could alter joint motion and eventually expanding the imbalance through the upper limb. In fact, Elisa Hayes' study also indicated strength weakness in the whole upper limb in LE individuals, including the wrist and shoulder. This complex pathophysiology may accord with the fact that most LE cases are chronic with high recurrence rate. There are some limitations of our findings. Firstly, the findings of altered muscle activation can determine whether it arises after an injury or precedes the actual injury, and further research on potential relationship between the cause and effect are needed. Secondly, dynamic muscle contraction was not included both concentric and eccentric, and further research are needed. And thirdly, non-unified intervention protocol and small sample size reduce the value of comparison between studies. To summarize, ECR activity level is reduced in LE subjects, which leads to modification of muscle activity pattern. This pattern may contribute to pathophysiology of LE from two perspectives, a cause or a consequence of LE. It may also lead to further impairments if not treated specifically and properly.
So we will now talk about the treatment. And in the following, we will discuss for the burning question whether the local elbow region the only place we are concerned for the LE treatment. In recent years, evidence has been provided for the correlation between the lateral epicondylalgia and also the shoulder muscle weakness, and it provides insight for us to know about whether the strengthening of scapular muscle can treat the lateral epicondylalgia. So first, we will now talk about the role of shoulder muscle on the lateral epicondylalgia. Scapula can serve as a pivot for the upper extremity movement because it can be the site for the kinetic energy to transfer from the trunk to the distal part of upper limb by the movement of scapula. And the study shows that there is a proximal to distal sequence of muscle firing in spots in which scapular protractor and horizontal flexor will be firing first, and then the elbow extensor and wrist extensor will be fired in the following. And this provides the evidence that for the scapula to be as a pivot. And besides, scapula is also a stable base for the upper extremity movement because scapular muscle will dissipate and absorb the force from the distal part during spots by contracting eccentrically to decelerate the upper limb and so as to absorb the force. As a result, if there is a weakness or fatigue in the scapular muscle, the elbow kinematics will be changed, in which elbow motion will be increased to compensate for the lack of range in scapula. Therefore, the energy demand and also the stress on the wrist extensor will be increased if there is a weakness in scapular muscle, and this is a predisposing factor for the overall injury and also a leading cause of elbow pain and injury in youth sport according to studies. Besides, when the symptoms of lateral epicondylalgia occurs, such as the pain, it will lead to a avoidance of muscle activation. Firstly, patient will have a voluntary alteration of muscle work in which they will use upper extremity in a more protective and guarded manner. And besides, there will also be a pain-induced muscle inhibition reflex, which will lead to the avoid use of forearm muscle in terms of neurology. And therefore, the activation of the scapular muscle and active warmth will decrease due to the decreased physical activity and also the neurology factor. And therefore, the prolonged disuse of the scapular muscle will lead to a further weakness. And the weakness, as mentioned before, together with the avoidance of muscle activation due to the symptoms of lateral epicondylalgia, a vicious cycle will be result, and it will aggravate for the symptoms of LE. Therefore, we would like to talk about the effectiveness of shoulder muscle strengthening on the treatment on lateral epicondylalgia. And we did some searching for the study, and we found that one of the papers shows that the 6 weeks of scapular muscle strengthening has a certain effect on treating the lateral epicondylalgia. And the result shows that the scapular strengthening can be used along the conventional treatment, and it can improve the pain, muscle strength of the scapula and also the wrist extensor, and also improve the functional outcome, scapula and also the scapular position. However, there is certain limitation in this study, which there is no true control group due to ethical reasons, and also there are no follow-up study to follow 1 year later after the treatment. And besides, the biggest limitation of this study is that it did not mention whether the assessor, therapist, and also the patient were blind. And the PEDAL score of this study is 7, which shows there's only a moderate quality. Besides, we also found other randomized control trial. However, the result is a little bit different. For the shoulder stabilization group in first study, and there's no significant difference in pain and grip strength after the treatment. And in the second study, the rotator cuff strengthening group has also no significant added effect on pain and functional ability. The lack of effect may due to the short period of intervention, which only lasts 3 weeks, and it may not adequate to show the treatment effect. Since the topic for the scapular muscle strengthening on the area treatment is relatively new, therefore the RCT is relatively limited. And we also find another case study to provide more evidence. This 3 case study also has patients with LE, and the treatment they take is only for the scapular muscle strengthening. And it shows a great significant improvement in terms of functional status, pain level, and grip strength. And this provides more evidence for the scapular muscle strengthening. In conclusion, shoulder muscle strengthening may have a certain effect, but it's very unclear on the treatment of LE. Although case studies show certain effectiveness of treatment, the level of evidence is low and the quality is inadequate. And for the randomized control trial, the findings in the studies is very different, and some show that there's a significant added effect of scapular muscle strengthening, but other has insignificant findings. And also the quality of research is inadequate as well, because the PEDAL score, most of it only score 6 to 7, which only have a moderate quality. And the research is very limited because on the database, 3 RCT for the scapular muscle strengthening is found only. And finally, the dosage type and also the mechanism of the muscle strengthening treatment is still very unclear and not organized to have a optimized effect provided. And the further research is required. And in summary, for the Brennan question, other than the elbow region, other parts such as elbow should also be taken into consideration. However, more evidence is still needed to provide a more optimal effect for the treatment.
Here we will talk about the prognosis part. From time to time, there are lots of studies or guidelines showing that LE can have many treatment choices, such as exercise therapy, manual therapy, or other modalities. However, which treatment approach is best is not known yet. One reason is the wide range of prognosis among individuals with the condition. Because of the wide range of prognosis, recent years, scholars have reinvestigated several prognostic factors to determine the effective treatment pathways. Interventions are more likely to be successful if individually tailored by considering them, including the types or stages of tendinopathy, the severity of pain and disability, the changes in pain threshold, the presence of concomitant neck or shoulder pain, the presence of sensory and motor impairments, and the psychosocial factors. This page shows the proposed management algorithm for patients with lateral elbow tendinopathy based on their identified prognostic factors and targeted initial and subsequent treatments. Patients are classified into low, moderate, and high-risk subgroups. Reassessment will be done after several weeks to determine follow-up interventions. With flashback to the pathophysiology part, pain system changes is involved in the multifactorial pathology model of LE, that is, the central sensitization changes. In this part about prognosis, we will further investigate why central sensitization, known as the cold pain threshold greater than 13 degrees Celsius, is considered as one of the poor prognostic factors. To do so, we have set up a search strategy aiming to investigate the reason behind. Two studies were obtained. The study done in 2015 with level 1A of evidence obtained data from 41 subjects in the placebo group in the research of LE patients and intervention. Baseline, post-treatment, and follow-up data including pain and disability level and cold pain threshold were measured by PRTEE and the thermal test system respectively. They investigated if cold hyperalgesia will lead to poor treatment results and found that greater cold hyperalgesia were significantly associated with greater pain and disability in both short-term and long-term. The second study in 2012 with level 1B of evidence obtained data including cold pain threshold from a total of 227 subjects. They investigated if any subgroups of subjects will have higher cold pain threshold. Results showed that only in severe LE cases, cold hyperalgesia was evident. This page explains more details about the first study. According to the baseline measurement, all the subjects being analyzed had cold hyperalgesia condition. After 2 months and 1 year, the pain and disability level is measured again by the PRTEE, and the relationships are constructed towards the CPT. Data suggests that even after a long time period, cold hyperalgesia still indicates long-term pain and disability, which means poor recovery and prognosis. This page explains more details about the second study. According to the thermal pain threshold data measurements and diagram, we can see that the mean differences for the affected site in severe LE subjects are more evident and significant when compared to the control group. This indicates that lateral epicondylagea patients presenting with severe pain and disability, as well as poor prognosis, could be distinguished by hypersensitivity to thermal stimuli. To conclude, apart from the well-known medical information of LE, our group has talked about some new ideas about the nomenclature, diagnosis, pathophysiology, treatment and diagnosis with the burning questions. As a students of physiotherapy, with such much of new knowledge related to LE, we should keep ourselves up to date and adapt to new thoughts and ideas. For example, in this presentation, shoulder involvement is one of our extra findings related to LE treatment and diagnosis, but there is no sufficient research to support this new idea yet. Let's stay tuned to see if any more surprising findings will be discovered in the future. And that's the end. Thank you.